Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. I hope you're all keeping well and safe. Thank you for joining me in my latest video. It's of a patient who attended with bilateral otitis externa with occluding debris, dry skin and a bit of wax as well. Now you can probably tell just by the approach into this patient's ears that they have very narrow, closed, slit ear canals. And this is the patient's right ear, and I'm actually using the endoscope not only to visualise the debris that I'm removing, but also as a doorstop. So I'm kind of using the tip of the endoscope, so we call the distal end, and I'm using that in the ear, and I'm pushing the cartilage to the left to stretch open the ear and keep it open, so I can then insert the microsuction tube, which you can see in view, which is called a Zollner suction probe. And we know it's dead skin here because it's really reflective. Skin generally is a lot more glossier than earwax, and as a result we get a reflection back from the light source that we're using to illuminate the inside the ear so we can visualise what we're doing. And you can just see there that I'm peeling it off the canal wall. Now, if you've been watching a few of my recent videos with cases of dry skin like this, I've found out, well, for myself, it's no clinical evidence, but anecdotally at least, discovered a link between women who are either premenopausal or currently menopausal and a build-up of dead skin in the ear. And this patient, upon querying her symptoms when they started, and she advised that she feels as though her ears are completely fine until she went under. She is obviously now menopausal, and ever since she was menopausal, her ears have been causing her problems. So one of the symptoms of menopause is many, as I'm sure some of you may be aware who are menopausal, but one of those is dry skin, and generally in different parts of the body, but more and more I'm discovering some anecdotal evidence, if anything, that they also can get this dead skin build-up in the ear. So I used some sodium bicarbonate drops there, and what sodium bicarbonate drops does with dead skin, it's a lot more effective than olive oil. Generally speaking, I use olive oil in procedures for earwax, but sodium bicarb is far more effective with dead skin, and it helps to bind it together. Now we can see the patient's eardrum, so her symptoms are alleviated, but she does have a bit of dead skin coating, enveloping her ear canal wall. And whilst I'm here, I'm trying to remove this. I couldn't remove all of it, purely because the patient started to develop the caloric effect. She got a bit dizzy during the procedure. So the caloric effect is when the coldness of the suction probe being in your ear. So when we suction your ear, it reduces your ear temperature. And each of your ears have an organ of balance. They're what we call the vestibular system, the semicircular canals. And these send signals to your brain. Now, if you're sat still and looking straight ahead, your brain should be receiving equal messages from both organ of balances. Therefore, your brain knows, well, we get an equal amount of messages from both sides, so we're stationary. But when we suction the ear, it reduces the temperature, and it actually inhibits the organ of balance in that particular ear, meaning that ear is then sending less signals to your brain. So your brain's getting more signals from the opposite organ of hearing, and it tricks your brain into thinking that you're moving. You're moving to the opposite direction. But then your eyes get confused, because your eyes also send signals to your brain, and it's telling your brain that you're not moving and you are stationary, and you develop vertigo when the room spins around. And it takes about a minute, it lasts for. And sometimes people can really feel nauseous, they can actually feel sick in the worst case scenario. And in the past, I've had a couple of patients, I've been doing this for about 6-7 years, earwax removal at least, that have fainted during the procedure, and it is quite daunting when it happens. But it's very rare. And they do generally come round, and even with the caloric effect, so like this patient, after a minute or so, once the temperature is restored, they feel fine. So you can see the eardrum, I've peeled the majority of the skin out there, and I just left that as it is. So the patient can hear significantly better. Now, this is the patient's left ear. Now, laterally at least, and when I say lateral, I mean near the entrance, it looks very similar, the consistency, as the patient's right ear. But once I've removed this lateral plug of dead skin, it's gone very mushy, just like the opposite side. More medially, the patient's got more dry wax and keratin. It's oxidised. It's a lot more dry and harder. So again, I've put some sodium bicarbonate drops in, and once more, I'm using the endoscope tip as almost a doorstop. So I've stretched the patient's ear back and up to open up the left ear to get access. I've inserted the endoscope just at the entrance and using the tip of the endoscope to push the cartilage to the right to keep the ear open, which then allows me to enter the suction probe into the ear and to remove this wax. If I wasn't able to stretch the ear open and keep it open, I wouldn't be able to get the suction probe in. And despite how narrow the patient's ear is, I'm using the full Zollner suction probe here. So this is the normal standard size Zollner suction probe. Just it's got this last piece now. It's slightly gone blurry just because we've put drops there. In a moment I'm going to come out, I'm going to wipe the tip of the lens just to clean it. And then I'm going to go back in. But because this is coming outwards, I don't want to just remove the suction probe because I'm bringing the wax out there. So this is near the entrance now. So I've just wiped the lens, stretched the ear open, going back in. You can see the consistency here, it's different. This is a bit more wax. It's been there for a bit longer, it's drier, it's oxidised. But again, she's got a very narrow ear on this side. So I'm just teasing this out. You can see there's little wriggle movements I'm making with the suction probe. I've got to be careful I don't remove the suction probe too quickly, because if I do, I will lose the suction grip. When you're performing the procedure, you can sense the speed at which you need to remove the suction probe. And if you do it too quickly, you know you're going to lose that suction grip. So you just use that instinct whilst doing the procedures. This is out the ear now. So similarly, you can see just how narrow that patient's ear is. Eardrum's intact, nice and healthy, just a bit of debris to the left. Just going to remove that very quickly. Going to mop up near the entrance, and in a minute you'll see some still images of the plugs of skin and wax that I removed. So this is from the patient's right ear. You can see it's enveloped by that mushy dead skin, and this is that last piece of dry wax I just removed from the patient's left ear. Well, I hope you enjoyed that video, guys, and you're keeping well and safe. Stay tuned, I will upload some more videos in due course. Take care, bye.